All right. It's 2:30 p.m. here in Zambia, and we'll be starting our presentation. The topic for today is methadone therapy and approach to opioid use disorder treatment for persons who inject drugs in Zambia. We have three presenters today. The first presenter will be Lina Kambilimba Mwango, who is the technical director from CHEP Zambia. Then he will be followed by Professor Welsh Christopher, who is joining us from the United States, Department of Psychiatry, University of Maryland School of Medicine. Then we're also going to have Dr. Yapoka Zimba, who is a clinician that looks after our clients at the MAT clinic. So we'll start with housekeeping rules. Just ensure that your mics are muted. It's important that the mics are muted so that the presentation can flow smoothly. If there are any concerns or questions that you're going to have, please feel free to use our chat box. And then at the end of the presentations, we'll be having a time where we'll be having our presenters, our presenters and also the network to interact. So you'll be able to raise your questions. We'll be taking note of that, and then you'll be able to raise the concerns or the questions that you have for us. So not to waste much of your time, we'll start with our presentation. I'll give it Dr. So Madam Lina Mwango will now take us through the first part of the presentation. Thank you.
All right. Thank you so much, Dr. Mubita, and welcome everyone to today's echo session. Our learning or presentation objectives this afternoon is we're going to learn about the background of PWIDs in Zambia, and then also understand the basic rationale for medication to treat opioid use disorder, and also the basic pharmacology of methadone. And also we'll try and also explain the role of methadone in enhancing treatment of opioid use disorder. So from objective 2 to 4, we're going to have Dr. Welsh take us through, but I'm going to take you through just the background. I'm sure some of you have seen this before from the BBS. So basically, Zambia conducted its first biobehavioral survey among people who inject drugs in 2021 through 2022. And basically, we defined people who use or inject drugs as persons who receive an injection, either self-administered or given by another person, of a drug that has not been prescribed by a clinician for that particular individual. So from the biobehavioral survey that was conducted in Zambia across the 3 districts, it was estimated, it also looked at estimating the population of people that were injecting drugs. So for Ndola, we had about 2,200 with a range of 1,600 to 2,900. In Lusaka, the estimated population was around 3,700, a range of 1,500 to 7,500. And then for Livingstone, we had an estimated population of 1,200, of course, a range of up to 1,900 people. And from the BBS, we were able to assess the age distribution among people that were found to be using substance. To note, in Livingstone, majority of the people that were using drugs were males, aged 20 to 24, and kind of an opposite with Lusaka. Lusaka had majority of the young adolescents and young women aged 20 to 24 who were actively involved into using substances, as well as in Ndola, we had those that were aged between 25 to 29 years that were using drugs. And in terms of the HIV prevalence, we see that majority of the PWIDs that are affected with HIV were actually, most of them were coming from Lusaka, and of course, the prevalence was ranging actually from as low as 5 to somewhere up to 48%. For PWID, in terms of the achievements towards the UNAIDS 95, we still are lagging behind. And broken down by provinces, we can see, by districts, we can see that in Livingstone, we had 72 and 73, and of course, just in the 70s, knowing their HIV status, being on ART as well as virally suppressed. Lusaka actually had the lowest in terms of those PWIDs that were on treatment, and their viral suppression was really low, around 40%, and of course, same in Ndola. So we see we're still, despite Zambia doing very well generally in achieving the UNAIDS targets, we're still having some pockets of our population still lagging behind in terms of the UNAIDS targets. And the BBS further went on to estimate or to look at what type of drugs were commonly used. And you can see Livingstone had the highest use of heroin, which is commonly known as Thai white, in the streets. And of course, we had also some dirty drugs, which is heroin mixed with others. We also had commonly known unga, which is the raw cocaine, opium, and of course, some other substances. And of course, after conducting the BBS survey in Zambia, we were able to determine that we had a problem, and this problem needed to be addressed by setting up an opioid replacement therapy, as we saw that even most of the drug that is out there and being used is mostly heroin, which is an opioid. So at this point, I will hand over to Dr. Mubita.
All right. No, thank you very much for the presentation. So if there are any concerns or questions or clarification that you want to make sure that they are addressed, we'll leave that, just take note of those concerns that are there. Then they'll be raised after Dr. Welsh makes his presentation. So for now, we'll hand over to Dr. Welsh from USA, Department of Psychiatry, University of Maryland, to take us through his presentation. Thank you.
Oh, hi, good afternoon, everyone. Can you guys hear me okay?
Yes,
yes, we can hear you. Thank you.
All right. So yeah, it's great to be here. I don't know if people are aware, but I'm going to be working with the team, and we'll be over there in May for a week to hopefully meet with, I don't know how many of the people here I would meet with, but I'm looking forward to it. So, all right. So just a little bit, again, I don't really know this group how much. I'm sure some of you have had talks on treating opioid disorder, and some probably not very much. But what we're here today to talk about is, and you guys are using the term MAT, medication-assisted treatment. I'm just going to be kind of using that with the term that a lot of other places are starting to use now, medications for opiate use disorder. And you might be wondering, why are we making a distinction? But partly here talking about medications only assisting treatment kind of really doesn't give enough credit to the fact that these medications that we're going to talk about are very effective treatments in and of themselves. So like I said, there are a lot of places now changing the wording of that to really recognize that the medications are in themselves really good treatments and aren't just assisting other treatment. I'm sure you're aware that a lot of different agencies, organizations endorse using these medications. Okay, next slide. I'm sure everyone here is aware of the WHO strategy for people who inject drugs, and you see there, number 2 is using these medications. So a lot of places are really recognizing this as an important piece. Next slide. And I really just want people to be thinking about this, and we can talk more about this, but a lot of people wonder, well, why should we put somebody who's addicted to an opioid on another opioid that they're going to become, and they don't develop addiction. We'll talk kind of about the distinction there, but they will develop likely physical dependence on it. So why would we do that for someone? And really just, to be thinking about this as a medication that we would use to treat any other chronic illness, like insulin, like antihypertensives. Also getting at that idea of the medication-assisted treatment versus this being a treatment in and of itself. Somebody with diabetes, type 2 diabetes, you might say, well, if you would just exercise and change your diet, you wouldn't need to take a medication. And that may be the same with someone with, high blood pressure, somebody with depression. If they might get in psychotherapy, they may not need a medication. But we recognize that a lot of people aren't going to be able to make all those behavior changes that might help a chronic illness, and that the medication. So, just as we're talking about this, for you to think about this in that same way. Next slide. So just a question, if people aren't aware, what do people think would be the main primary reason for using medications to treat opioid use disorder?
All right, feel free to answer. All right, so far we are at 23%. Let's keep answering. Let's just indicate, pick the option that you think is correct. Of course, we are going to cover this afterwards.
There's 172 people.
Okay, we'll end our poll once we've reached 50% of at least 50% of the participants. So we encourage everyone to participate, please. This is anonymous. No one will get to know who has answered which question. Right, we'll end here with the poll.
Okay, yeah, I don't know how it works. Do I go on with this? But yeah, so it looks like a lot of people picked C, and in general, that's the correct answer, though really none of them are wrong, except with B, you're not really replacing one addiction, but you are replacing, as we talk about, one medication that acts at the same receptor as heroin. So you are, like I mentioned before, usually someone is going to develop physical dependence. So, but that really is different than addiction. A and D, in general, that wouldn't be recommended, but there might be circumstances which the person is not able to get started on a medication that they would stay on. And so methadone could be used to help eliminate withdrawal in circumstances where they can't stay on it. So real quickly, we'll just go through, and I'm reading through kind of the guidelines from ZAMBIA about the medications. It looks like the plan is to have all three. I just have up there the three that are FDA approved in the US. So methadone, buprenorphine, naltrexone. I'm not we'll talk more about all of those a little bit, but methadone is what we're really going to focus on. That's the primary medication now in Zambia. I think buprenorphine and naltrexone are going to be available. I just want to really quickly mention, because you'll hear about this in the news, there are other countries that are now using more medications to treat opioid use disorder, hydromorphone, long-acting morphine. They're being used in some Eastern European countries. Canada now has added those as medications that are used specifically to treat opioid use disorder. Just in case you've not heard this, or again, it's in the news, a number of European countries, Australia and Canada, actually have clinics where people go in and use heroin in the clinic. So again, not done a lot of places. We don't do that here in the United States now, but that's a thing that, again, a lot of European countries and Canada are doing. And then I listed at the bottom there other things that are being looked at. You see there's a lot of research on different hallucinogens like psilocybin, ibogaine, if people are familiar, is found there in Africa. Kratom is in Asia. So these are a lot of things that some people will misuse, but they're also being looked at to possibly treat opiate use disorder. Click again. And just to be aware, none of these are kind of like really ready to be used yet, but just to be aware of what's going on. There's research now looking at you guys I don't think have fentanyl there, though it's something that would be good to look to see if there's any. But here in the United States, pretty much all the heroin has been replaced by fentanyl. So there's actually a fentanyl vaccine that's being developed that would block fentanyl from working in the brain. Transcranial magnetic stimulation is also being studied as also deep brain stimulation. So again, none of these are ready to be used clinically, but there's a lot of research being done looking at things that can help people with opioid use disorder. Next slide. So again, people wonder, well, why put somebody on methadone when, if they're already using another opiate? These are some of the big advantages. It's orally administered, not injected, has a much more gradual onset, longer half-life and duration of action, can produce pretty clearly complete blockade of the effects of heroin. And there are some side effects and issues to be aware of, but most people don't really have a lot of chronic problems from methadone. Next slide. So this is just kind of showing pictorially what the hope is when you're putting somebody on methadone. So if you see the black or the dark blue there, that's somebody using heroin. And if you inject heroin, within seconds, it's in your brain. You have that really intense high. That lasts for, minutes to maybe an hour. And then you start going down into a kind of more normal comfort zone. And then once you're physically dependent on short-acting opiates like heroin, then you start to go into withdrawal. And so once they're addicted, they're doing that multiple times a day, going through that kind of spiking cycle. The idea with methadone and buprenorphine is that kind of middle pink, where you're hoping to get somebody to have blood levels that kind of keep them from below the level where they feel high, but above the level where they start to go into withdrawal. So that's really the idea of using methadone and buprenorphine. Next slide. So again, there's lots of research. Methadone's been around since the 1960s in a lot of countries. So there's been a lot of research on it. So the research all shows, significant reductions in using illicit opioids, increased retention in drug treatment, reduced criminal activity, reductions in HIV and hepatitis infections, transmission, reductions in other, soft tissue kinds of injuries from injecting, just improvement in general mental and medical health, and a lot of people just kind of getting back to their life, able to work, do things with their family again. Young people get, staying in school. So a lot of benefits to society. Next slide. So this is a really important slide because it really hits on one of the major benefits of treating opioid use disorder. So if you think of the general population having a risk of mortality at 1, when people are actively using opioids, the risk goes up to 6 times that. If they can get on the medications for opioid use disorder, it doesn't go all the way back down to 1, but you see there, kind of looking at a bunch of studies together, it goes down below 2. So really, really significantly helps reduce mortality, both specifically from opioid overdose, but even in most studies for all-cause mortality. So really, really important benefits just for overall decreasing mortality. Next slide. Looking more specifically at benefits with HIV. So again, studies showed decreased mortality with HIV specifically. I just have one example there from British Columbia and Canada, where they looked at people on and off methadone and buprenorphine, and the mortality ratio when they were on methadone and buprenorphine was 12. When they were off, it was up to 30. So significant differences between when people were on versus not on medications for their opiate use disorder. As far as looking at antiretroviral treatment, different studies look at different things, but kind of looking across the board, you see increased improvement in recruiting people onto ART, adherence when the person's on it, retention and treatment overall, and then just looking at population coverage. It really helps to have people have the option to be on MOUD. Studies showing positive effects on viral suppression, reduced HIV risk behavior, and then less data, and part of what we'll be looking at is limited, looking at the effects of people adhering to PrEP. Next slide. So people also wonder, well, how long should somebody be on methadone? And again, I had in the beginning talked to you about thinking about this like other chronic illnesses. So there are some people that, they're on methadone for a while and then come off and they do well. But the majority of people, this is from one study, but others have shown similar rates that, each 3-month interval here, significantly more people relapsed to using heroin. And if you think about, one use can be fatal, somebody overdosing when they relapse. It's really, compared to a lot of other addictions, the consequences of relapsing are much more serious. And you see here in this study at 12 months, 82% of people had relapsed. So a lot of people, it's really, concerning that thinking of this as a short-term medication, and some people, like other chronic illnesses, may need to stay on medications for life, or at least for a long time. So it's why we have to be thinking in that way and trying to set up the treatment so that it's something that somebody can stay on chronically if they're benefiting from it. Next slide. All right, so who's eligible for getting on MOUD in Zambia? So you have to meet criteria for either an opioid use disorder, is what the Diagnostic and Statistical Manual of Mental Disease number 5 calls it, or ICD-11 calls it opioid dependence. We'll talk a little bit more about that. So you should be 16 years or older, though if there's somebody with significant opiate addiction and they're under 16, it would make sense for them. That can be arranged as long as there's parental consent. And then the person has to be able to provide informed consent. Next. So this is the criteria for substance use disorder in the DSM-5. And what's important here is that you see the top two, tolerance and withdrawal. So that's kind of how we define physical dependence. And usually with opioid use disorder, people are physically dependent, though in theory, you could have somebody who say they were incarcerated, they weren't able to get opioids, but they wanted to be on it. You could start somebody on it if they have a history of opioid use disorder. But what's important here is you can have even mild opioid use disorder with just two of the criteria, but the two cannot be just tolerance and withdrawal because physical dependence is a real thing, but that's not a disease in and of itself. So you really have to have one of these other things at least to have an opioid use disorder. And you can see they have to do with inability to control your use significantly affecting your physical health, your social other things, using despite having had other negative consequences, craving for it. So there has to be some other kind of impact on your life that is also part of what's going on. It can't be just being physically dependent. Next slide. All right. So just a little bit of quiz based on what we've just talked about. So you're seeing a 30-year-old patient who's HIV positive. He's been using cocaine IV daily for over 10 years. He's unable to control his use, has lost multiple jobs and his marriage because of it. Would he be eligible to be referred to the MAT clinic?
Network, let's just make sure that we continue participating. Is poll number 2. So far, almost 50 seconds have passed, and we are only at about 49-50% of participation. Let's participate.
Okay, well, it looks like we kind of have the idea of what people are thinking here. So this was a little bit of a trick question. So this guy here that you're seeing is injecting cocaine, and even though he's an IV, according to this, an IV drug user, I don't have anything in here about him using heroin or opiates. So it's really important. Oops, we're getting echo. Okay. To remember that methadone, buprenorphine, naltrexone, those are treatments for opioid use disorder, which again, cocaine is not. So you would obviously want to help the person using cocaine, but you putting them on MOUD wouldn't be helpful for that. All right. The second poll here, you're seeing a 25-year-old female patient, HIV negative. She's been using oxycodone orally daily for over 10 years. She's never injected. She's engaged in sex work to obtain money to buy the pills. She's having other consequences from her use. Would she be somebody who could be on the MAT clinic?
As we have been doing, please let's participate. Let's continue participating. So far, we've been doing very well. Let's participate. So far, almost over a minute, we're still less than 40% in terms of participation. We are more than we are close to 190, but so far less than 80 have participated. Please read through and pick the answer of your choice. As usual, this is anonymous. No one will be able to know who chose which answer, but at least we'll be able to gauge our knowledge and our understanding of this topic. Thank you.
Okay, so it looks like we have about half people who've weighed in. So yeah, it looks like the majority picked B, which, you know, that's certainly the best answer. It really depends how you set things up. Dr. Claassen and I helped the Kenyans set up the methadone programs there, and initially that was actually only supposed to be for people who were injecting. And once we started doing it, we found that there were actually a fair amount of people who didn't inject and really only smoked, yet they had significant problems. And certainly, even though she's HIV negative, you would really like to prevent her from going down the road of maybe switching over to injecting, or to otherwise be at risk for acquiring HIV. So yeah, I mean, it's really best to have it set up so that it doesn't really matter how the person's using it. You're still hopefully reducing risk of them to developing HIV. Next slide. So just a reminder of the the kind of basic pharmacology of the medications that we're going to talk about. So when we're talking about methadone, heroin, all the full opioid agonists, you have this kind of, pretty dose dependent increase in activity at the mu opioid receptor, which is good for managing pain. The risk of that is that as you go higher, that also you run the risk of suppressing respiration. And so that's why dying from opioid overdoses is pretty common, and pretty much anyone you can give enough opioid to decrease their respiration. Next. When we're talking about partial agonists, that's what buprenorphine is. And again, we're not going to focus on that today, but so at the lower doses, buprenorphine acts like a full agonist, but then it has a ceiling effect where you're not getting much more effect no matter how much somebody takes. So it may make it a little bit more limited as far as analgesia, but it's a much safer drug because it has much less effects on respiration than methadone does. So again, it's a medication that really can help, especially if you're worried about giving people take-home doses. Take-homes with buprenorphine are just going to be much safer if someone uses it that otherwise doesn't use opioids. And in the lower there, the red triangles, that's naloxone or naltrexone. So naloxone is what we give people if they have already overdosed to reverse an overdose, and then naltrexone is a oral. There's also a injectable form of it that is used to treat opioid use disorder chronically. And there you're getting you're blocking the receptors, so you're really blocking other opioids like heroin from attaching to the mu opioid receptor. So that's how that's helpful. for people to not continue to use. Next slide. Just a little bit, again, just to be familiar, if you're not working in the methadone clinic, the dosing isn't as important, but just understand that the lower doses often help people manage their acute opioid withdrawal symptoms, but often at those lower doses are going to still have craving, and if they continue to use, then they'll continue to feel the effects of the heroin. So usually if you raise the dose even more, it helps with the craving. And then raising it even more acts as what we call a blocking dose. It's maybe not a full absolute blockade, but blocks it so that the majority of the effects of somebody using heroin, they don't feel it. So the hope is that that'll help them, significantly reduce or even stop their use, because they're just kind of wasting their money. They're not getting high from it anymore. Studies have looked at optimal blood levels. The majority of programs do not actually measure blood levels unless somebody's at a really high level and they're still continuing to use and crave. And sometimes you want to see if the person might be a rapid metabolizer or whatever. But but there are blood levels that seem optimal. And then looking at the dosages, studies looking at higher doses show that the patients tend to do better. Next slide. There are some chronic medical conditions just to keep in mind when you're looking at especially methadone. These are less important with buprenorphine, but for methadone, with older age, you're just not metabolizing as well. Your liver is just not functioning the same as you get older. So that can put somebody just at risk that their body won't be able to metabolize the methadone as well. Cardiac syncope, their methadone can lead to QT prolongation. So you want to be monitoring for that. If people otherwise have really significant liver disease, cirrhosis from maybe alcohol use, that can affect it. Other significant respiratory problems, because it can also suppress respiration. Opioids, all opioids, including methadone, also work at the endocrine system. So sometimes that might be an issue. Sleep problems, especially sleep apnea. Methadone can cause sleep apnea by itself, or it can significantly worsen sleep apnea if the person already has it. So that's something else. Other chronic disabilities and acute and chronic pain. So none of these are reasons to not start somebody, but they're reasons that you just would be more cautious as you're treating them, maybe go up slower on the dose and just monitor them more closely. Next slide. So there are a lot of drug-drug interactions. We'll talk about some of them specifically, but you really need to be careful with other things that can suppress respiration, especially benzodiazepines, barbiturates, and other opioids. Other things that are sedating. A lot of times people who misuse heroin, and even when they're on methadone, they'll use other medications that add sedation, because they think that's kind of, they'll call it boosting their high. So you just need to be careful with that. We'll talk more about the metabolism of methadone and how that can be affected. I mentioned earlier that QT, so adding another medication that can also prolong QT to methadone can raise the chances of that happening. And then also being careful just of other things that can impact the metabolism of the QT prolonging medications. Next slide. So as you're starting people, you want to really start at a low dose and go slowly. There's no way to really predict by somebody telling you how much heroin they use a day. There's no way to really predict how much they're going to need to be at a stable dose. So you just really need to kind of monitor people as you're treating them, and base it on their report of symptoms, but also seeing how they're doing. Do they look sedated or intoxicated when they're getting it? So this is showing, I mentioned one of the big benefits of methadone is that it has a much longer half-life than heroin. There's a huge variation. It can be anywhere from 12 to 36, even 48 hours. So there's a lot of variation. But we usually talk about for most people, it's roughly 24 hours. So the problem is that especially as you're starting somebody out with that long half-life, it means that each day that you're going up, you're going to accumulate, if it's a 24-hour, you can get half of the day before a dose, a quarter of 2 days before a dose. So you really need to be careful, especially as you're initially going up, to just go slow enough to make sure that you're monitoring how the person does. It's hard with clinics because it also, people don't hit the peak serum levels from a dose for 3 to 4 hours after they take it. The way most methadone programs work is the person comes in, they take their dose, and they leave. So the people at the clinic never see the person at the peak serum levels. So it's also why it's really important to talk with, if you're treating somebody. Also, it can help to involve their family with the treatment, because people that are around them the rest of the day may see how they're doing more than you see at the clinic. Next slide. So I mentioned before metabolism. There are several other P450 that methadone is metabolized by, but by far the main one is P453A4. And that has really significant impact on metabolism. It doesn't have any, it has a metabolite, but it's not active. And I mentioned before, some people may be rapid metabolizers, but next slide. What's more important is that there are a lot of medications that either increase or decrease. So this is a list of some of the main that can increase. A lot of them are pretty commonly used medications. And then similarly, these are medications that inhibit P453A4 and can lead to, somebody can be on a really stable dose. You start them on one of these, and within a couple of days, they can actually overdose because they're not able to metabolize the methadone as they had been before the medication. Next slide. So just, as we're talking about how to kind of work with people, really important if the providers, the HIV or other medical providers are not in the clinic itself, it's really important to communicate. Let the methadone program know, this person developed seizures. We're going to be starting them on phenytoin. If the methadone clinic is aware that somebody may be started on one of the medications that might induce P453A4, then they can be ready to start raising the dose to help the person not go into withdrawal. And similarly, if you're going to put them on an inhibitor, they can work with you to lower the person's dose if they're not able to metabolize it as well. So really can be useful to be communicating with the program. And like I said before, educating the patients and educating if there's family that's involved and the patient's willing to have their family involved, it can really be helpful to also talk with the family members to what they can look out for as far as signs of the person being over medicated or going into withdrawal, or things like, if they're developing QT prolongation, what to look for from an arrhythmia and things like that. Next slide. Some of the common side effects of methadone, it's a full opioid like other opioids. So some of these are things that you're going to see with any opioid. Many of them, the person, once they are on it for even a few days or weeks, they develop tolerance to a lot of the side effects. So, but some of them can really persist and make it difficult. So most of them are things you can treat with other things like constipation, decreased libido. Opioids, all of them, including methadone, do affect the hypothalamic pituitary pituitary adrenal axis, so they can impact on sex hormones. So you need to watch for that. But again, most of the side effects are, they develop tolerance to, and they're manageable. Next slide. Just some of the disadvantages, and I'm sure that the people that helped get methadone there in Zambia had to deal with a lot of these. It is a full agonist, so people, if they're using it and they don't have tolerance, they don't, regularly use opiates, they can overdose on it. So it's something you need to be aware of, and it, gets into this needing for people to have the take-home doses. Or come in every day to the clinic. It can really, if the clinic's set up so that you can never get take-homes, it can be really hard for patients to come in 7 days a week, 365 days a year. So you kind of have to balance the, making it patient friendly versus the risk of giving take-home doses that can be diverted. If somebody eventually wants to come off, and can be, you're on a full opioid and your body has developed physical dependence to it. So that can be a little difficult. Big one is there's just tends to be poor public acceptability. So, no one wants a methadone clinic in where they live. So, I'm sure a lot of these issues you guys had to deal with getting it approved there, and then finding out where you're going to put it, where it would be most helpful, where patients can get to it, but also having to kind of balance out with the people in the community where the clinic is. Next slide. So just lastly, to talk a little bit about the care model. So you can think of either where the person goes to two entirely independent programs, one where their methadone is, and one where their HIV care is. You can have coordinated care, so there's still two separate programs, but you have case managers, you have peers or community outreach workers, people that help coordinate the care. You might have parts of the care split. So say the HIV provider is not in the MOUD clinic, but they dose in the clinic. So people take their HIV, their antiretrovirals with their methadone. So all the treatment isn't there in the MAT clinic, but some of it is. And then, if you can do it, integrating the care and co-locating it is definitely better. So having it all in one place, you can either put the HIV treatment in the MOUD treatment program, or you could do it the opposite way. It's harder with methadone, but certainly buprenorphine can be provided out of an HIV treatment program. You could do it in a third setting, like in a primary care or even an obstetrics clinic, where you're treating a lot of people with HIV and opioid use disorder. And then there are other models where you're doing it even in a non-traditional medical setting. So doing it within a drop-in center or a syringe service program, doing it in a pharmacy itself. A lot of other countries, that's how they mostly do methadone, is the person goes to a pharmacy and takes it. They don't come to a clinic. The way in the US we do that, and that's the way you guys have set it up. But a lot of other countries, the usual way to get it is from a pharmacy. Correctional facilities might do it when somebody's hospitalized. And then the last thing with those pictures are showing is also you can have different kind of different versions of, so you can have a brick and mortar clinic, but you can also have a mobile. It's just pictures of in Nairobi, the mobile methadone program that they have, and it's connected to a physical program. So it's not freestanding. Every morning, you see on the picture to the left, the little bottles are put in a container and they're taken out, and the van goes to different places, just further from the central city, and people just come to the van and get it. So there's lots of different ways to think of the models, but still you can integrate the HIV and the MOUD care within a lot of these different ways of thinking about it. Okay. All right, so yeah, just some of the really key points. Again, big one is that MOUD really has significant effects in decreasing mortality. Just remembering it's a very safe treatment in general. Again, there is that risk of overdose, but most people take it appropriately, and as long as the staff is monitoring, it can be a really safe medication. Really, with this group, talking about how it can really help with ART and HIV. A lot of research showing that it really helps increase adherence and retention with that. And then again, a lot of research showing that coordinating those treatments really has better outcomes for both HIV and their opioid use disorder. I don't.
All right. No, thank you very much for the presentation, Professor Welsh, Christopher, and also the presentation that we had from Ms. Lina Mwango. So the presentation was done very well. So now we want to hear from the network if they've got any questions or concerns that they want clarified. And then we would also like to hear from the panel of experts. So far, we have taken note of the presence of Dr. Claassen. I don't know if there's anyone else that is in the meeting from our experts. Please feel free to make a comment or to make any contribution that you'd like to make. Thank you.
Hi, Dr. Mubita. I have a couple of comments, if I may.
Yes, please.
All right, thank you so much. So good morning, good afternoon, everybody. My name is Dr. Cassidy Claassen. I work with UMB. I've lived and worked in Zambia for since 2015. First of all, I want to just say thank you so much to Professor Welsh for making time today to come and speak to us. I think we've all learned a lot, and this is truly a masterclass in methadone therapy. I wanted to explain a little bit about infectious disease and methadone. So as you may know, I'm an infectious disease doctor, but I work closely with Dr. Welsh, both in the hospital and in our research program. And that's because there's a lot of overlap between people who inject drugs, addiction treatment, and infectious disease treatment. As Prof. Welsh has explained, people who are on methadone therapy and on HIV treatment, they tend to have better outcomes for both diseases, both addiction and HIV, especially when the treatment approach is combined. So if they can receive their antiretrovirals and their methadone therapy at the same location, they get better viral suppression and ART adherence. Madam Lina and others in the room will talk a little bit about the UTH MAT clinic that is launching, but we hope to be developing an integrated care model there that will support people. A few clinical notes from the ID doctor, just to add here, is that first of all, when you're treating people who inject drugs with HIV, with both methadone and ART, there are some certain interactions that you need to watch out for. So I think we saw Prof. Welsh listed the CYP3A4 inhibitors that can either inhibit or either prolong use of methadone or cause rapid metabolism of methadone. So one has to be cautious when prescribing ART for interactions with methadone. The second thing is that the most common reason for people who inject drugs, the most common reason for their interaction with the healthcare system is actually infections. They develop a lot of skin and soft tissue infections like abscesses or cellulitis from their injection practices. They also may develop bloodstream infections or cardiac infections like endocarditis. So the ongoing use of injectable drugs presents a risk factor for infection. for many reasons. One, socioeconomic, they tend to be in rougher living situations. Two, over time, they tend to get colonized with more pathogenic organisms and have malnutrition and other things that lead to weakened host defenses. And then finally, the act of injection kind of introduces a pathogen into the bloodstream. So there's a lot of overlap of infectious disease and addiction treatment, particularly in this population. And we'll be looking to collate some of these services at the UTH MAC clinic. So I just wanted to add a couple of comments there. Thank you so much. And team, we're happy to take questions for Prof. Welsh about methadone therapy, etc. Please go ahead. Mubita, over to you.
Thank you very much, Professor Claassen, for your remarks as one of the panel of experts. If there are any other panel of experts that you might not have taken note of, please feel free to come forward. If there are any comments or concerns that you want addressed, please do so. And then for our network, please, if you've got any question, you can write it in our inbox chat, or you can raise your hand. We'll take note of that, and then you can raise those concerns. So far, we have one question from Mwenya Mubanga. Great presentation, Professor Welsh. Are there any clinics testing or using GLP ones for addiction control in our type of settings?
So there are some studies going on using the GLP-1s for the most evidence so far is with alcohol. And there's probably, think about alcohol as a little bit more like using it for the original intent. But yeah, there are studies now looking at it for cocaine, for opioids, cannabis. So yeah, there are. I don't know how close we are to those being used, but as they're just being used much more in general, I think that we will see them being used more for addiction as well.
Thanks, Dr. Mubita. I'm actually driving. I'd just like to thank Professor Welsh for the very good presentation, and my friend Lina for the background presentation. And of course, Professor Cassidy giving us a little bit of extra information there. By way of introduction, for the sake of Professor Welsh, obviously, I'm Dr. Duncan Chanda. I'm the director for the Adult Infectious Disease Center, and we champion the setup of MAT with the support of CHEP, of course, Lina leading. And we are learning a lot of things. I'm an infectious disease consultant, so my focus also, as each where is beyond providing methadone and managing the MAT clinic, is the issue of how integrate HIV care, hepatitis B care, and TB, which is my other baby. Yeah. We are doing this slowly, getting things in place, and thanks Professor Cassidy for bringing up the issue of drug-drug interactions. I think that will be one of the bigger challenges. For the network, we only have one MAT clinic so far at University Teaching Hospital. We initially started with plans to have the University Teaching Hospital, Kitwa, Ondola, and Livingstone for obvious reasons, like Lina presented. The government has taken a commitment to actually take this as a routine medical service, but mindful also, obviously, we have an opportunity now also to do a lot of research, clinical, public health, social, and etc., for us to optimize this service provision. Yeah, so yeah, thanks very much for the presentation, Professor, and thank you for the questions. I think I've answered one question in the postings. Thanks a lot.
Thank you very much, Dr. Duncan Chanda. He's one of the members of the panel of experts. So at least we've heard from them so far. So what we'll do now, since there are no any questions that have been raised, there's one question that has come, saying that maybe this is more for Dr. Claassen. With the levels of stigma around substance misuse, abuse, how are we balancing community messaging on the mat clinics with ensuring the right people receive care? So there's that question that has been raised in the chat box.
Yes, this is actually more of a question for Madame Lina Mwango, so I'll get started and I'll turn it over to her. I think this is a very important question. So the questioner raises the concern around levels of stigma around substance use, and this is clearly a concern. It's a clear concern in Zambia. It's a concern in the U.S. People may be ostracized or made to feel bad about their substance use. I think first of all, for us as medical providers, it's important to remember that addiction is a disease, and we treat addiction with methadone in the same way as Prof. Welsh was saying. We can treat diabetes with insulin, or we can treat hypertension with chlorthalidone. So keeping that in mind, so that we as providers do not stigmatize our people, but we recognize that they have a disease that needs treatment, and we can help provide that treatment. So I think stigma reduction starts with us as healthcare providers. And then, Madam Lina, over to you for discussion of how we can engage the community to make sure we're reaching the right people with the right care. Thank you.
Thanks, Dr. Cassidy. So like you rightly put it up, a substance use disorder is not a moral failure, but it's a disease. So I'm sure even the same way all these other conditions are managed, it's the same way that should be managed. We've been working closely with a number of community key stakeholders, including civil society organizations, as well as people that are managing the rehabilitation centers that are around in Zambia to work around stigma. And I'm sure once we have the right educational materials, which are currently under review, they are going to be used as one of the tools to do more of community education, and not just targeting the people with substance use, because the stigma really comes from the family as well as the community members. So our approach will be basically to target the entire community, including the family especially. And not to preempt, Dr. Zimba will come up very soon with a very interesting case from the clinic, and you will see some of these questions that you have asked around stigma and how we can actually keep or reach the targeted population to receive this service. Like Dr. Chanda mentioned, this is a government initiative and the services are being provided for free, and we really need to make sure that the targeted our community or population really receive this service. So maybe I can end here for now. And then I'm sure when we are discussing the case study, some of these things will be brought up. Thank you.
Thank you very much, Madam Lina, for that contribution. And I'm sure she has really tried to elaborate on many important aspects that pertain to Zambia. So we have another question in our chat box. Wanted to find out, similarly, curious to learn of the role of law enforcement agencies, such as DEC, in this program.
Okay, so like I mentioned, we've actually worked very closely with the Ministry of Home Affairs, where the Drug Enforcement Commission falls, and we've worked closely with the Drug Enforcement Commission to develop the guidelines. And I think the team from our
just
Thank you. So the team from the drug enforcement really spearheaded the development of the education materials that are currently being finalized. So DEC has been greatly involved in the setting up of the MAT clinic, the initial assessment, as well as the follow-ups. We've been working closely with them to make sure that things are being implemented within and in accordance with the current laws of the land. So I can confirm that the drug enforcement has been actively involved. And for those that didn't know, there's a unit under drug enforcement, which is called the Education and Counseling Unit, where even people that are suffering from substance use disorder do receive further support in terms of counseling and further education. And drug enforcement has really good programs, which they do sometimes run on radio as well as in the community to really educate people on the dangers of substance use. Thank you.
All right, thank you very much.
Thank you. Let me add quickly to what Lena has just said. Just for information, the attempt to set up this clinic has been on since 2011 or somewhere there. And then I think we picked it up in the last 5 years. Myself, Lena, our colleagues from Drug Enforcement, Ministry of Home Affairs, ZAMBIA, and all other regulating bodies. So, of course, one of the issues was exactly on the question you asked. So when we did a visit in Kenya, we had a presentation from the equivalent of drug enforcement. We had a lot of issues initially here, but then eventually, like Lena said, we emphasized that for us, from our point of view, these are patients. But however, we still run in that question where people ask, is it safe if I come? I still, after living through the HIV pandemic, and then the COVID pandemic, and then now this drug pandemic, you learn a lot of things about the law. So one of the things I tell people, like for instance, do you know prostitution is illegal in Zambia? Homosexuality is illegal in Zambia. But as a healthcare person, you should never have that judgmental position. You're dealing with a patient. And I would like to encourage healthcare workers who could have patients with this kind of addiction problem to get in touch with us, and we see how we can help that patient. It's because we are healthcare workers, we're in a different space. But we are very happy that the DEC, the Home Affairs, Ministry of Home Affairs, actually literally supported us in the last 5-6 years. We openly to make sure that we actually get this. So yeah, we are covered as healthcare workers, and let's help people with these drug use disorders. Thank you.
All right, no, thank you very much. The other question that I was asking in the chat box, just someone who wanted to know, of course, our title should have been with those abbreviations. So OUD, that is opioid use disorder. The TX just stood for treatment. And the PWID, that was just people who inject drugs. So there was a question again from Jackson Mwa, who wanted to find out if are there any specific art clinics for persons who inject drugs in the highlighted provinces. What are the challenges affecting the triple 95 achievement in this marginalized population? So 95 in Zambia. So in these different provinces where this MAT clinic are set up. So are there specific art clinics for persons who inject drugs in the highlighted provinces? And then what are the major challenges affecting the triple 95 achievements in this marginalized population? Maybe the panel of experts, they can come through, and also Madam Lena.
Okay, I can start. Okay, go ahead, Dr. Chanda.
Yeah, so I can explain it in a different way. So, as you are aware, our HIV program over the years, we have been focusing on key populations. And people who use drugs or substance abuse, we have put them in that group. Particularly at UTH, at our center, we have a dedicated clinic for key populations, and we put all those together. Like I mentioned, this is the first MAT clinic we have at own at UTH. However, the key population program focuses on people using drugs, focuses on female sex workers, focuses on MSM, also adolescents and young adults. So we, of course, if you look at our HIV rates and ABC, they're higher in these groups. So we focus on those, but we also are very aware, for instance, PWIDs tend to be not based in one place. So someone can come in the clinic, disappear, and ABC. So we don't achieve that separation. That's why I think when Lina presented that, her presentation was alluding to that. So one of the motivations for the MAT clinic, and this is why my colleagues were asking, what are you infectious disease people doing there? I said, in our country, these are among the key populations pushing our HIV rates, but also we need to help them get off the addiction. But key to that is to also prevent HIV, hepatitis, syphilis, tuberculosis, which tends to be high in this group. So we treat and we prevent in this group. Yeah. So for the time being, it's only UTH MAT, which is transitioning into that. Then as we set up the MAT clinics in the other provinces, then we'll do the same thing. But currently, we're just using the key population clinics. Thanks.
Thank you very much for the responses. So we'll now move to the next part of our presentation. The pause were already addressed by Professor Welsh. So now we'll come to the case presentation.
Thank you. So good afternoon, everyone. Thank you for your participation, and thank you to Professor Welsh, Professor Cassidy, thank you, Lina, and also thank you to Dr. Chanda, and also to our moderator. So I'm Dr. Zimba. I'm going to take you through one of our clients' history, both medical, socioeconomic history, as well as some of the challenges we've been experiencing. And yeah, we'll go through some questions and see how best we can assist our clients. So our client is a male 43-year-old who has opioid use disorder, admits to use of heroin with polysubstance use, that is cocaine and marijuana, also HIV, currently on TOD, but has history of default. So this is a client who initially was being assisted by the community at Sanity House and was later referred to a clinic, but of course, because of stigma and other issues, missed some of his dosages. So also came in with trauma, which is secondary to assault by non-people, and also has mental health comorbidities. So this is moderate depression and moderate anxiety. But his mini mental state was normal, sorry. So he's currently on 20 milligrams of methadone, which is a supervised dose daily. Unfortunately, his first visit to the clinic was on the 5th of January 2026, but to date, he's only received about 15 doses. So socioeconomic history is that he's homeless, has history of prior incarceration, the recent assault, which happened in December and again in January, and also family estrangement. So this is a client who initially was stable, had a good job, but unfortunately got separated from his wife. He also has 2 children. So this is the socioeconomic history. Going on to the physical examination, So this is on a particular day, on the 6th of February, which we thought was something we could present. His general condition was fair. He was pale, afebrile, not in respiratory distress, and he was unkempt. So his pupils were constricted, equal reaction to light. His chest was clear with bilateral air entry. Cardiovascular system, the S1, S2 were normal, and per abdomen, it was soft, non-tender. So musculoskeletal, we noticed a reduced range of motion in upper and lower limbs. This was due to the assault. Of course, he had the one that had happened in December, had another one happen late January, and then he had multiple wounds on the whole body. So because of this, he was sent to the surgeons in casualty where he was actually admitted and treated. So during the time that he was admitted in the surgical ward, we had to take his dosages to him, his dosages of methadone, so that he doesn't miss. And I think those few days that he was admitted was the most consistent that he was with us at the clinic. So our current challenges for most of our clients, of course, transport barriers, lack of socio-economic support, lack of the urine drug test kits, which is one of the most important things for us. And then there's also the issue of polysubstance use, then mental health comorbidities and social instability. So with our urine drug panel testing for this particular client, like I mentioned, he's in and out of the clinic. He's not a client who comes on a daily basis. But for the 5th and the 8th, we have these results which show you, we can start with the first one. Cocaine was positive on the first day. The amphetamines and methamphetamines as well as marijuana were negative. Then we have methadone, which shockingly was positive before we initiated methadone. And ecstasy was negative, opiates such as morphine and heroin were positive, barbiturates were negative, and then benzodiazepines were positive, and tricyclic negative. So on the 8th, so he already skipped from the 5th, he skipped 2 days and came on the 8th. So on the 8th, cocaine again was positive. Amphetamines, methamphetamines were negative. And then this time, marijuana was positive as well as methadone. Ecstasy was negative, just like before. Opiates were still positive, barbiturates were negative, benzodiazepines were positive, just like before, and tricyclics negative. So with our lab results that we were able to trace, of course, this is a client who was already confirmed reactive. His ALT was at 20.8. We had no creatinine on the file. His initial HB is 10.8. Hepatitis B was negative. Viral load showed the target was not detected. And he's currently on TLD. So our questions so far. Firstly, how can we effectively support social reintegration for our clients? Secondly, how can we establish an efficient system for multidisciplinary team treatment of clients? So for this particular question, like I mentioned, this is a client who, yes, we are managing for opioid use disorder, but came in with history of trauma, also has psychiatric conditions. So what tends to happen is that once they go to different clinics apart from the methadone-assisted clinic, there is more or less stigma, and patients complain rather that they are not treated the same way as they are treated at the clinic. So another question is, how do we address the challenges of transportation and housing that are faced by our clients?
So, thank you very much for the presentation, Dr. Yapoka Zimba. The presentation was very good. We're still going to, there are these questions that are in front of our screens. If anyone feels they want to maybe make a comment on the questions that have been asked, please feel free to come through. And then I think this was the last slide. If there are any questions, concerns that you have, again, also feel free to bring them forward. Thank you. I don't know if Dr. Welsh has any comment on this question that have been raised, or if Dr. Claassen also has any question, any comment or any contribution, you are most welcome to do so. Or if Dr. Duncan Chanda also has any answer, contribution, or any response to any of the questions that have been raised, please feel free to come through. Thank you.
Yeah, well, I mean, I can just comment here in the US where we've been using methadone for, over 50 years. We still struggle with these exact same issues. So, it's always going to be an issue. I think it's just trying to do our best and hang in there with the patients, understanding what they're facing as far as stigma. It's easy to just say, well, that's all it is, but it's, to be the person who's living through that, it really is a big issue. So just trying to help with them. Again, trying to set it up so if you can integrate all of the care into one clinic, that helps with, having to move to other medical settings where there is maybe more stigma. I think number 3, the challenges of transportation and housing. Housing, I don't have any good answers for. Again, it's a huge issue we have here in Baltimore as well. Transportation, though, you just do want to be aware of where patients are coming from, what's reasonable. And over time, as treatment expands, and figuring if you find that there are a lot of people coming from a certain area that's just very hard for them to get there, are there any other things you might be able to do? Set up a satellite, a van that goes out to these further areas, things like that. But again, these are bigger kind of system-wide issues that it's really hard, and it can be very frustrating working in the field of HIV and addiction, where every day most of the people you're seeing have to deal with all these issues, and you really just can't solve all of those issues for them. They're bigger kind of policy things that the government needs to address, but you still have to work with the people and try to help them as best you can. So sorry, there was no good answer, but that's what we're dealing with.
Yeah, thanks, Professor Welsh, for that answer. It's true. We are struggling with that. There's no good answer. But from the experience, when I was young a medical student, we were training in the 90s, and HIV was basically a death sentence. And there was so much stigma, a lot of it, until we involved a lot of social scientists who came up with how to approach the stigma and things like that. And definitely it improved. Over the years, we have been struggling with why we are not actually getting to elimination. And one of my opinions has been, we used social scientists early in the epidemic. When we got the ARVs, we forgot about them. But we still have that human nature to deal with. So my argument has been, we need the social scientists, and we probably need medical anthropologists to get to the bottom of this. Then concerning supporting individual patients, the only thing we have in our law is the Ministry of Social Welfare have approached them already, and they can only support things like transport, and this, but it will take us a long time. For the time being, we just have to encourage the patients to come through, and also support the families to understand why they have to support the patients. So that's where we are, because the Ministry of Social Welfare and Community Development, their issue is we gave them this challenge recently, so they have to factor in how they're going to get personnel involved and to what extent. So we're really stuck. We're in a very bad space as health care providers. And obviously, our patient, like the one she has presented, is also in a very, very bad space. And that's not only patient. There are lots of other patients who are having these challenges. Yeah, unfortunately, there's no good answer at this moment for this. Thank you.
Yeah, I'll just weigh in. Thanks, Dr. Chanda. I'm laughing because you guys, I was expecting you to bring very specific medical treatment questions like, what dose of methadone should we start, or what interaction should we be careful for, or these kinds of things. And instead, you brought some very complicated, very hard to answer questions around this case, which I recognize these are big meta questions. In many ways, I would actually turn this back to the Zambians on the call and say, these are the questions we need to challenge ourselves with, and how do we now develop local Zambian approaches to these? I think Dr. Chanda is right on saying that we have experience from the HIV epidemic. If you think about how stigmatized HIV was 20, 30 years ago, it's nothing compared to, drug use isn't even close to HIV, I don't think. So we've combated stigma in our healthcare system before, and I think we can do it again. So I think we'll have to take lessons learned and take a new approach. In terms of transportation and housing, I think recognizing that many people in Zambia also face these challenges, and so this is something we can take on with community health approaches, reaching people in the communities where they are. And in terms of number 2, an efficient system for multidisciplinary team, I just wanted to introduce that we're working closely with Methadone Clinic at UTH to start a new study called the INSPIRE study. My colleague, Prof. Marie-Claude Lavoie, is on this call, and she's working with me and Prof. Welsh. We're working with Dr. Chanda and others at the Mac Clinic to kind of assess a multidisciplinary integrated approach for treatment. And we hope that is successful and can kind of bring together both MAT treatment as well as HIV treatment and treatment of other comorbidities in a one-stop shop for these people. So more to come on that. Thank you so much.
Thank you very much for the wonderful responses that have been given. We have a few, I think about 3 questions from our chat box. One of the questions is that despite a few centers providing MAT clinic, do we have a referral structure on how other districts and provinces without the access to this service, how they're able to refer the clients for MAT care?
Okay. Thanks, Dr. Mubita. I will let Daniel speak first, and then I can take up. I've seen his hand has been up. Maybe you can allow him to talk.
Yes, yeah. Please come through.
Thank you very much. This is Daniel Mbazima from Sanity House Rehabilitation Center, who were involved with the community aspect of MAT. So very lovely and exciting presentations. Just to address the questions that I hear, I think my contribution would be we should also extend help beyond the MAT clinic. There are recovery groups that exist, like Alcoholics Anonymous and Narcotics Anonymous. Those are groups that can provide extra support where clients can go to and seek further help. Also, another aspect is in addressing the issue to do, I think also Chinamas too has group sessions, if I'm not mistaken. They still do have group sessions. A number of rehab spaces around also do have group sessions. So that would really, really be important. In line with stigma, I think MAT in itself and MOH should establish a referral system in regards to what most of these clients are going through. For instance, if there is a case that has to do with extra medical help, there should be a proper referral system and everybody should be involved, and that should be based off the challenges that most of our people have. For instance, most of our females struggle with UTIs as well as STIs. So that's one thing that would definitely come up. The more female clients come up, the more that's going to be there. And in as much as we may look and address these things from the MAT clinic, we may also refer these people where they're coming from. Another important thing in line with transportation, I've heard transportation being a challenge for a very long time since this meeting started, but it's because we don't have any family involvement. We put people on this program, and we know the state that these people are on. Having run a rehabilitation center, all these years that we've been running, I think for about 5 years now, it's less than 10 people that have checked in and have paid for themselves. Most of the support comes from the family. So I feel if somebody is going to be initiated on MAT, we reach out to the family, tell them, look, there is what could help, because families at the end of the day don't want to see their loved ones struggling with an addiction. In as much as they're tired, in as much as they're fed up, everybody would be happy to hear there is something that could eventually help. So if we have a situation where we're getting people from hotspots from Bwalya and we expect them to make it through for transport and whatnot, which is why it's easier for the guys to, why should I find about a 50 or 100 kwacha every day for me to go for transportation, or I can use something cheaper than that to get high. So the issue of transportation needs, when a person comes through, we sort of establish family links, who within their family is going to come through. If you're calling from UTH, Ministry of Health, I don't think families are going to refuse or deny, but because of the respect that people have for the facility in itself. So I feel transportation challenges and all these other housing things, when a person is initiated on MAT, let's also try to reach out to the family. Of course, others may not want to, but I feel it would go a long way because our clients economically, they're not in a position to. Thank you very much.
Thank you very much, Daniel, for those wonderful contributions and comments. There's a question, so we've taken note of all the comments that have been written in the chat box. So yeah, it's just that we're just pressed against time. Otherwise, all of them would have been addressed. But there's just one question. I think two questions for Dr. Welsh. The first question was that how best can a poly drug user be helped, considering that the current services are only for opioid? And then the other, in addition to that, say that is fentanyl legal in the USA? If it is, how is it regulated, considering that it has claimed hundreds of thousands of lives? Thank you.
Yeah, so both of those could take a while to answer, but just real briefly, so the polysubstance use, I mean, unfortunately, the only really, it's in the US at least, we have FDA approved medications for alcohol, opioids, and nicotine. So certainly if they're also drinking, you want to at least consider, and I'm not really sure what's available there in Zambia, but you know, using disulfiram or antabuse. Naltrexone has also been used for alcohol use disorder. Another medication called acamprosate. So certainly if they use alcohol, seeing if they might be able to benefit from that. Engaging, I think Daniel was talking about trying to get the person in with more counseling, Narcotics Anonymous. They're here in the US, even though it's not FDA approved for that, more and more, there have been a few positive studies with topiramate, or Topamax is an anticonvulsant, also used for migraine headaches. So we will use that for cocaine or amphetamine addiction off-label, but that does help some people. But I think it's more just trying to address other substances. I don't know how much benzodiazepines like Xanax or alprazolam are common there. I know they're very common in Nairobi. So if people are misusing other substances, also trying to figure out, are they using them to try and kind of self-medicate an underlying mental health issue with depression or anxiety? As far as the question about fentanyl, so almost all the fentanyl that is in our illicit drug supply is not prescription fentanyl. So we use fentanyl for, prescription fentanyl for managing pain, but this is all illicitly manufactured. Pretty much all of it, the precursor chemicals come in from China. they go to Mexico, and then in Mexico they're synthesizing this this non-pharmaceutical fentanyl that then gets smuggled into the country and distributed all over and is used. So so yeah, it's not really pharmaceutical fentanyl that's getting out on the streets and killing people. It's and it's not just one fentanyl. There are about a couple dozen fentanyl analogs. So it's a bunch of things, and then there are even newer synthetic opiates that are making it on the market that aren't even fentanyl. So it's but it's almost all things that are now being manufactured in Mexico and then smuggled in and distributed, throughout the country. It'll be interesting to see. I mean, I don't know enough there where heroin, if it's mostly coming in still through Kenya and Tanzania and then down to Zambia, or does it come in a different source than what's seen in Kenya and Tanzania? So I'd be curious to see where it's coming from, and just to see, is there any indication that some of it might be adulterated with other opioids? I don't think it's being really seen in East Africa, but I know some over in Nigeria and some in the West, there has been some heroin that's been found to have fentanyl in it. So it'd be, I mean, the program's just getting started, but it'd be nice if we can try and use the program also to do a little bit of surveillance and see if there are other things that might be being added to the heroin.
Thank you very much for everyone. Thank you very much to our panel of experts. Thank you very much to the presenters, Madam Lina Mwango, Dr. Welsh Christopher, and Dr. Yapoka Zimba for the wonderful presentation. So this is where our presentation ends. So thank you very much, and also to our network.